Good evening to everyone and welcome to today's presentation. It's a wonderful experience at the end of the one full year of preparation to share this paper discussion with all our students who had been enrolling for the past 1 year. Probably this will be a last opportunity for me to see a good number of you who already have finished the coaching and also a successful exam for this year. If we look at all these questions of APPG 2008, I only feel it like one of our Sunday test papers. Not much big deal. A good number of questions on Barter's syndrome, androgen insensitivity syndrome, and the traditional questions. Finally, it is that prepared aspirant who feels that it is easier, and less prepared aspirant obviously feels it tougher. But no wrong with the examiner. Examiner is an examiner at the end. So with that spirit, let us make this start, Doctor. But before we start the discussion, let me extend my thanks to Dr. Syed Inayatullah, Dr. Samira, Dr. Saujanya from our Vizag Center, and our Tirupati, Karnool, Guntur, Varangal, Kakinada and Vijayawada students who within a 1 hour of time they have written all the questions and sent. That should be the spirit of academic spirit that should prevail. So let us make the start of today's discussion. Some of the questions may have little difference from what you have seen in the actual exam, so don't become annoyed about it. Please give your correction so that we will try to incorporate probably if the frame of the question was little wrong or probably atypical. What is not a branch of the internal maxillary artery? This is our traditional question. There are totally 12 vessels. Any entrance you go. How many of you are the next year 2009 aspirants, Doctor, among you? Oh, very good. A very good number. That's good. So for the 2009 aspirants, once more let me tell you, standard topics, standard questions. There should not be any amount of hesitancy in the exam hall. So 12 vessels. Aorta, internal carotid, external carotid, and the branches of them, they are the favorite areas, totally 12 vessels and their branches you have to be sure about. The maxillary artery is one of the two large terminal branches of the external carotid artery is what you need to basically remember. What are the two terminal branches? One is superficial temporal and the other is the maxillary. In turn, maxillary has got the first part, second part and third part. That is how it is being divided. And from the first part of the maxillary artery you have deep auricular artery, anterior tympanic artery, middle meningeal artery, inferior alveolar artery and accessory meningeal artery are all the ones which are arising. So what are the options that are correct, Doctor? That means inferior alveolar is arising definitely, and also the anterior tympanic is also arising very much. Then from the second portion, what are the branches of maxillary artery? You have mesenteric artery, pterygoid branches, deep temporal and the buccal artery. And from the third portion, the pharyngeal artery, infraorbital artery of pterygoid canal and descending palatine artery. So there is a reason, Doctor, out of all this, the odd man out becomes the inferior tympanic, which is not a branch of it. Now let us take up the next question. Posterior division of the obturator nerve typically supplies which important areas? Another standard question. Lumbar plexus and brachial plexus. Definitely one question comes from this topic you have to be doubly sure about. So the obturator nerve arises from the second, third and fourth. L2, L3, L4 is the root value. The obturator nerve basically is responsible for all that sensory innervation along the medial aspect of the thigh. And also it is important for the motor innervation of all the adductor muscles of the lower extremity. What are they? The external obturator, pectineus is innervated by it, adductor longus, adductor brevis, adductor magnus and gracilis. So it is only the external obturator, not the internal obturator, which is innervated by the obturator nerve is what we need to basically remember. Now the question comes, what is then in that case, obturator internus muscle is innervated by whom? If it is not by the obturator nerve proper, then who is innervating it? There is a nerve to obturator internus. on its own. Which is the one which is innervating both the obturator internus and the gemellus superior. They are the two things which are innervated by it. So what is your final answer, doctor? So obturator externus, knee joint and adductor magnus are innervated by the obturator nerve, but not the obturator internus, which is innervated by the nerve to the obturator internus, is what you need to fundamentally remember. Anthropozoonosis, very traditional question. Last week subject test discussion we had this. Any infection which is transmissible under natural condition from the vertebrate animals to the man or vice versa are called zoonosis. Now if the transmission occurs to man from the vertebrates, it's called anthropozoonosis. You have rabies, plague, hydatid disease, anthrax, trichinosis, where from the vertebrates to the man the transmission occurs. Then you call zooanthroposis if it is occurring from man to vertebrate. For example, the human tuberculosis causing a cattle to get infected. Then amphixinosis is in the both ways, that is a Schistosoma japonicum and Trypanosoma cruzi are the examples of amphixinosis. Standard question. Without, it's a very frequently tested old question. Some of you can note, make a note how many were really old questions. One of the common thing after the exam is over is what will be the score of our competitors. Forget about our score. Because if our competitors naturally, fortunately, and to their misfortune, have done more mistakes, at least we can become toppers, right? So, how much will be the score? It's very simple calculation. The number of traditional questions, typical questions which are there will decide the median score. I think that 150 to 160 must be the traditional questions without any second thought. Using Cauda equina you can answer in this exam. 30 to 40 at least are relatively atypical. I think till now there are no atypical. Probably first one, maxillary artery, we must have ignored. We still can put it as a atypical question, right? Now, point epidemic, traditional question. The disease agent is brief. It occurs simultaneously and within one incubation period, and it has got a median incubation period where 50% of cases occur within that period of time. And the epidemic rises and falls very rapidly without any secondary waves or without any kind of plateau. They are all the features of the point epidemic. So C becomes the answer. Secondary waves are not seen and all the cases occur simultaneously is what need to be remembered. Another traditional question in SPM, cross-sectional study. The first 100 pages of PARC itself, epidemiology will decide 1/3 of questions in preventive medicine question bank. So we must be very sure that cross-section is also called the prevalence study. It tells about the distribution of the disease in the given population. It does not speak anything about the etiology. That is what exactly is tested. It tells about etiology is not a true thing, it is wrong about it. And it also provides information about the prevalence but not the incidence is what need to be remembered. What is 10% dextrose? Actually, it is a nursing exam question. It is hypertonic, no big deal. Suddenly, don't think in exam hall dextrose become metabolized to water and water leads to fall of osmolarity and that lead to development of hypotonic. Why don't we consider, I mean, we can consider anything which cannot be right also. Now, let's go to the next question. Conn syndrome. This is a very good, yeah, how many of you would like to consider hypotonic? Nobody? Yeah. Is there any other? Okay, just take a small correction of answers. Sometimes typographical mistake, there can be an emergency for the typist. His wife may call or girlfriend may elope. Instead of A, he may type B. That is not the issue. Once more, I like to tell you that what is the comfort in taking a coaching? At least you can accuse the teacher. He gave a lot of mistakes in the Sunday test, that's the reason I did not get the seat. So, you are the best judge, doctor. No teacher, no book is final. So, let's go to the next question. Conn syndrome. What is the difference between primary hyperaldosteronism that you see in Conn's versus that of the secondary hyperaldosteronism that you see when we become dehydrated? When we become dehydrated, intramuscular volume will decrease, that will decrease the renal plasma flow, and that will stimulate the renin-angiotensin system, and that in turn lead to development of aldosterone rise, which is called secondary hyperaldosteronism, which occurs when we are edematous or whenever we are dehydrated. So in that situation, what do you see? A rise of aldosterone along with a rise of renin and angiotensin. Whereas primary hyperaldosteronism means without the need of any renin itself, because there is an adrenal adenoma, there is excess production of aldosterone, which in fact will go and suppress the renin. So low renin with a high aldosterone is equal to primary hyperaldosteronism. High renin with high aldosterone is equal to secondary hyperaldosteronism, is what you have to be doubly sure about. Now let us take up the next question. Bartter syndrome, Liddle syndrome, Gitelman syndrome. If you know this, you are like a distinction aspiring candidate in medicine, general medicine, undergraduation, right? So we must know about these three syndromes. Many times we discuss this question, but still let us talk about it. The Bartter syndrome and Gitelman syndrome are the examples of the tubular salt wasting disorders. We lose salt from the body in these two disorders. If there is no salt in the body, do you have hypertension? No. Anything that retains salt will cause hypertension, losing salt will cause either hypo or a normotension, but not hypertension. So there is no question of seeing hypertension at all in Bartter or in the case of the Gitelman, is what you need to basically understand. Now the question is, why are these people? I'll take a couple of minutes of your time because we have a good number of 2009 aspirants in this crowd. Why we are losing salt in the case of the Bartter syndrome is my question. We have a beautiful thick ascending limb of loop of Henle and the distal convoluted tubule. They are the two locations where the chloride become actively reabsorbed. And there is one location in the nephron where it is passively reabsorbed. What is that? In the proximal tubule. So whenever the patient has got a Bartter, he has got a problem with his thick ascending limb of loop of Henle, where the sodium potassium chloride co-transporter is abnormal. It is mutant. So they can't actively reabsorb the chloride. So they lose the chloride, they lose the sodium, and that is how it becomes the salt wasting type of condition, is what I like to underscore to all of you. Now whenever we are losing NaCl into the urine, what it will do? Will it go simply like that? No, it will suck the water and also takes it away from our body. And because of that, what will happen? We become volume depleted. When we become volume depleted, intravascular volume will come down. And that will once more stimulate the kidney to produce more amount of renin-angiotensin. From where? From the juxtaglomerular apparatus. So that is the reason they have a hyperplasia of the juxtaglomerular complex because of the long-term stimulation caused by the dehydration, caused by the salt losing, is what need to be basically remembered. And every time the juxtaglomerular apparatus is stimulated and it is producing a lot of angiotensin, what is the effect of angiotensin fundamentally? Angiotensin also has got another bad effect. It will cause the vasodilating prostaglandin E2 to become elevated. And this elevated PGE2 is responsible for the growth inhibition in the children. So what do you come across in Bartter syndrome? A growth retarded child who is losing the salt into the urine, who does not have the hypertension, is what you typically come across.